Good morning.
Good morning.
Morning, sir.
So we're going to start general surgery today. Uh, like I said, this is the bread and butter of our job. Wherever we start, we start at this specialty. First couple of years, uh, the employer like us to spend in general surgery and OBGYN surgery, urology, and some plastic surgery procedures uh, to build up our uh, foundations. Once we learn uh, these procedures and we can do them proficiently, they ask us what specialty we like to go next. Or some hospital, they have this orientation where they put people through different specialty for the first 6 months. They spend, they usually like us to spend uh, do all the procedures that's available through general surgery first. It may take uh, month months, and after we're done with that, then we move to OBGYN and urology and plastic. Then we do some orthopedic uh, general fracture management case, not the total joint, total hip, and all those things. General cases like fractured ankle, uh, ORIF, fractured wrist, leg, something that is uh, very, very general in nature. And we use that drill measure, tap, screw, those Synthes technique. After the orthopedic is done, then we are advanced to neurosurgery, basic neurosurgery, making burr holes, starting craniotomy. That's about it, and some back surgery and cervical vertebral surgery. Then we move forward to go back to our regular schedule, and we get scheduled at general surgery cases. After you are working in general surgery for a few months or maybe about a year or year and a half, they would like you to specialize depending on the hospital's protocol. Some hospitals, like major hospitals, they like us to pick one of the specialty or two specialties and kind of uh, become really, really highly proficient on those, become the resource person also. Others, where you have to take calls and if they don't have specialty team, they like you to just kind of rotate everywhere. So the first 2 years in any case, you are going to uh, only you're going to only see uh, you, you're only going to see okay. You're only going to see some of these uh, general surgery areas, the cases about uh, hernia repair, cases about gallbladder repair, some small bowel obstruction cases, colon repair, or colectomy, or sometime uh, of total colon resection. Sometimes you get partial colon resections. other associated problem with large intestine, small intestine. Sometimes there are tumors on the omentum. So those type of repair, mostly abdominal cases, and uh, tons of endoscopic, laparoscopic cases. So uh, the modern trade is to do almost everything using endoscopes, minimal invasiveness, and it cuts down the surgery recovery time, and the patients are not receiving that huge hospital bills, and they can go back to work as soon as they're recovered. So we will kind of refresh our memory, starting from the, let's get that pointer first. Starting from the oral cavity and going back to the pharynx, oropharynx, which is the common area with the trachea, and then we go to the esophagus. That is our long channel passage where the food comes and migrates through the mouth to the stomach area. Esophagus goes through a hiatus, as you remember, on the diaphragm. And then it reaches the stomach, and stomach kind of then becomes narrow, and that becomes part of small intestine, which is the duodenum part. And duodenum takes the food, transports it to the jejunum and ileum. It's a long part of the small intestine. Ileum then attaches to the cecum part of the sigmoid colon, the cecum part of the colon, ascending colon, where we have the appendix, that accessory organ, is still present in our human being. The cecum then goes upward, which is the ascending colon, and at the junction where the liver is there, from there it turns transverse, and then it becomes transverse colon. And where we have spleen, from that flexure it goes downhill, become descending colon, becomes sigmoid part, S part of the sigmoid colon, rectum, and anal canal. We also have pancreas, which is a major endocrine system that has ducts, comes to the area of duodenum, where pancreas brings in the pancreatic fluid to dissolve, to digest food. And we also have liver on this left side mostly, and another small lobe on the right side, right next to the stomach. Liver produces the bile. Bile then goes to the common hepatic duct into the cystic duct to store in the gallbladder. So gallbladder is a storage for bile. When it is required, the gallbladder sends out the bile through the cystic duct into the common bile duct into the duodenum to emulsify fat. the bile has one job. Fat does not get, is not water soluble. So fat will not be dissolved or be digested through the process. That is why bile emulsifies the fat, kind of uh, 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 makes the fat digestible. Without bile, the fat related food, we will not be able to digest. It will just come in from one area of the stomach and go out through the rectum, anal canal, outside of the body. So gallbladder uh, and the liver together, they work to make this fatty food to digest. Now, uh, the area that we are going to see some surgery would be the esophagus, the hiatus, where the esophagus is coming and becoming the stomach part. The entire stomach, we may have surgery there. Duodenum, pancreatic duct, gallbladder and gallbladder duct, small intestine, large intestine, appendix. The surgery will be involved in all of these organs. Now, if we go to see some of the terms associated with our general surgery, is adhesions. This is basically when two separated structures originally they stay separate, but previous surgery causes them to build up scar, and they kind of attaches to the abdominal viscera, the organ, to cover it, to envelop those organ, and they make a banding, they make scar tissue formation, and in total, those scar formations and the banding are called adhesions. Now, anastomosis is a terminology relates to when two lumens of intestine or vessels are attached together by surgical procedure, by suturing, by using stapling device. When two lumens of intestine or vessels are kind of sutured together or stapled together to make a continuous passage, continuous lumen. For example, if you cut a garden hose in half, and then you decide, okay, I need to put it together. When you put together the garden hose with clamps and all that, that is anastomosis. That can be done for any lumens in the abdominal cavity or anywhere in the body. The vessels that we have in the leg, if it is dissected and then rejoined together, that's anastomosis. So anastomosis is a term we routinely use in general surgery. We cut piece of a small intestine for obstruction, and then we you join the rest of the intestine together so that the bowel, the food can move, digestion can take place, the bowel movement can continue. So anastomosis is important aspect in general surgery. Atresia is basically when a normal lumen uh, normal opening, a normal passage of the structure of our body closes, blocks. That is when the example would be like that is something like biliary duct. When the biliary duct is blocked, closed, or the area of esophagus makes the food impossible to go through because of the esophagus has now closed on its the loop of the esophagus. The lumen of the esophagus is closed. That would be esophageal atresia. Bile, we just talked about it. It is a alkaline fluid to emulsify the fat that helps absorption and digestion of fat. And liver produces it, and gallbladder stores this bile so that when time comes, the gallbladder can secrete the fluid through the duct system. And that duct system we are referring here as a biliary tract, through which the bile comes to the duodenum area. Diverticula, this is when the lining of any organ such as colon or small intestine is blocked because of a pouch, false pouch-like formation, a blind pouch that forms through the lining of this wall, the canal, the organ or lumen. The lining of our colon has mucosa and serosa, and those area becomes a small pouch, kind of protrudes outside and become a small pouch. That is what we call diverticula. And colon is the large intestine. So ileum comes and joins the initial part of the colon, which is the cecum area, and then it runs through ascending colon, transverse colon, descending colon, sigmoid colon, and it becomes rectum, the total length of the colon. Colon, the large intestine, usually absorbs the fluid from the food. So all the fluid contents that is there, water absorption is taking place here in the colon. All the water that we drink, that is being absorbed here in this part of the colon. Dysphagia means when someone is having swelling problem, swallowing problem, something they have when they are having dry mouth, or they're having difficulty in swallowing food material, even a fluid. Fissure is a narrow opening or crack in the tissue, forms naturally. Fistula is again a passage that forms in between two hollow organ or two lumen, which are located side to side, or one organ which is very adjacent to another organ. In between them, we have this little lumen or passage that forms and creates this fistula, abnormal structure that causes a lot of problem for inflammatory reason, for infection process that can grow there and causes the blockage of the passage to which the normal secretion can take place. Fistula can be repaired, fissure can be repaired using some minor surgical technique. Interception is a process where a sac-like formation takes place. Invagination of proximal intestine into the lumen of a distal intestine. That means part of the lumen kind of folds and stays inside the part of the next section of the lumen. So for example, we have a duodenum, and then next to the duodenum is jejunum. Now duodenum kind of inverts into the jejunum and forms this little section of obstruction called interception. If you have a tube, a flexible tube, and if you push the both end of the tube, what happens is because of the tube is flexible, what happens is the tube, a section of tube slides onto the other area of the tube, becoming a loop-like creation in between that section of the tube. We'll show you in picture to give you better idea. Okay, let's look at. Here is a part of stomach and becoming duodenum. Now, the lumen of duodenum is connected to the stomach lumen. Now, if this lumen progresses, this part of the lumen emerges inside of the duodenum, and like here, there is a little pouch, little constriction caused by this movement of the stomach's flexible lumen into the duodenum, making the duodenum opening narrow. or we could call it stenosis of the pyloric muscle. This would be a form of interception. So when we are talking about this interception, that interception is that folding of that proximal, the original part of the intestine, into the distal, the later part of the intestine, causing a obstruction. That would be interception. So that requires dissection. This is one of the cases where we need to have small bowel obstruction surgically has to be removed. That section of that interception area has to be surgically removed. So, digestive tract, as you know, involved in digestion, absorption, and elimination of the waste product. That food that we eat, we get digested here, nutrients are absorbed, and the rest of the waste material has to be eliminated from the body. Sometimes it is called alimentary tract or alimentary canal. Sometimes we call it just intestine, large intestine, small intestine. And we have primary organs like liver, secondary organs like pancreas, gallbladder, spleen. These are all the organs that is associated with this digestion process. Upper, that would be the part esophagus and stomach all the way up to the duodenum, and then the lower part, which would be the colon, starting from the anal canal to rectum, sigmoid, all the way up to the ascending colon. So divided into significant sections: lower GI tract, gastrointestinal tract, and upper gastrointestinal tract. So it starts from the mouth, opening of the mouth, and ends at the anal canal. Continuous lumen through which food is emerging, food is moving from mouth all the way up to the anal canal, while in the middle of this journey, the food is being, the nutrients are being absorbed, and the waste products are being eliminated from the body at the end. So that is our digestion process. That is our digestive tract doing. So esophagus. From mouth, food comes through this oropharynx and reaches this tube right behind the trachea. Esophagus is located posterior to the trachea. Trachea is anterior most, and we can feel the trachea, the cricoid process and all these things of the trachea. And then right behind it, we cannot feel, but that is where this lumen of esophagus starts with the sphincter muscle, upper esophageal sphincter. So esophagus continues and passes through the diaphragm and enters the stomach. we have another sphincter muscle there, lower esophageal sphincter. So anytime we have to do any work on the esophagus, we have to either come from the lateral margin so that we don't disturb the trachea and the mediastinum organs like heart or lungs, or we have to do it through a scope. Very difficult to work around the esophagus because it's the location. Thoracic surgeons are always involved when the general surgeon wants to do any repair of the esophagus. Sometimes they have to remove the esophagus for cancer. Then the thoracic surgeon and general surgeon, they work together, they open up the cavity. The mediastinum area, posterior part of the mediastinum cavity is open, and the adjacent structures are retracted, and general surgeon do the work on the esophagus. Stomach is a storage area for the food that we eat. So it's a pouch. This pouch has a lining of mucous membrane and serous membrane. Serous membrane is the layer which sits outside, and mucous membrane is the layer which is the internal layer. And if you lift up the mucous membrane, then we find there is stomach muscles, layers of small stomach muscles. That stomach muscles, that muscular layer, helps the stomach to do the process of peristalsis, to let the food transport from the top to the towards the bottom part of the stomach to the duodenum. And at the same time, it allows the food to kind of mix together because of this muscle. The food is mixing with the enzyme, acid, hydrochloric acid is possible. Fundus, body, and antrum, the pylorus part. Fundus is this area of the stomach. Body is the rest of the stomach, and pylorus is the or antrum is the last part of the stomach. Nerve that is help or signaling the contraction of these muscles, secretion of the hydrochloric acid, secretions of these enzymes, including pepsin, comes from cranial nerve. Cranial nerve 10, which is the vagus nerve, that comes and lines the stomach, this medial area of the stomach, the interior area of the stomach, it lines up. It lines the esophagus also. Vagus nerve emerges out of the foramen of the cranium and then continues its journey all the way through the esophagus, to the lining of the stomach, and progresses. And cranial nerve is a parasympathetic branches of our autonomic nervous system. If you remember, we have autonomic nervous system where These nerves, they work automatically, spontaneously. Two divisions, one is parasympathetic, another one is sympathetic. Parasympathetic works is a branch is the cranial nerve 10. This, when we are relaxed or we are sleeping, not doing much of physical activity with the leg or other part, lower part of the body, or running or doing or some active status, that is when the parasympathetic nervous system uh, sends out impulses through the cranial nerve 10 to secrete hydrochloric acid and enzyme to help digest the food uh, in the stomach. And when the digestion process is complete in the stomach, the bolus, the food material, then moves to the duodenum part through this pylorus junction. So cranial nerve 10 sends out impulses to secrete those fluid, hydrochloric acid and enzyme, and to help the digestion process, to contract the muscles of the stomach. Now, when the body is active, like you are doing walking or running, you need blood to go to the other areas of body, like the leg. That is when sympathetic branch of this nervous system works, and that shuts down cranial nerve 10 to secrete any type of fluid into the, or digestion, to start any digestion process in the stomach. All the blood from the abdominal cavity now diverts to the leg muscles. So that is what autonomic nervous system do. When we are facing some danger, then this autonomic nervous system has this fight or flight mode. Either you gather all your blood to those areas where you can run, get away from the danger, and that is when the sympathetic nervous system works. Heart rate goes up. Your blood is now going towards the leg to allow you to run fast and get away from the danger. Or when you are relaxed, that is when parasympathetic branches works and helps you to do the work that is necessary to gain nutrients for the body, to store up energy, to gather energy from the food, to digest food, do all the work that is necessary to maintain the body structure. So autonomic nervous systems, two branches, parasympathetic and sympathetic nerves, they work all the time, alternatively. And cranial nerve 10 is part of this parasympathetic interventions. The reason we're talking a little bit about cranial nerve 10, because we have some surgeries that is involved with cranial nerve 10 that we will discuss. Now, stomach functions. As you all know, stomach main function is to store food, then to mix food with the hydrochloric acid and digestive enzymes, and the muscle of the stomach kind of works here to mixing up these this food and the juices of the stomach. Then the stomach transports that food, empties that content into the small intestine through a pylorus sphincter. small intestine then starts to dissolve this uh, uh, food with the juices from the pancreas, from the bile, from the liver, the bile comes and kind of makes this uh, a content of food with these pancreatic and biliary juice to make it uh, available for the small intestine to absorb the nutrients. Further, digestion takes place and the nutrients are then being taken out, and the stomach, whatever the content the stomach has done, that kind of progresses through the small intestine into the large intestine through a process called peristalsis. Peristalsis is a wave-like uh, uh, movement of the food through the intestine, small and large intestine. Small intestine now extends from this area, which is located near the pancreas and the right liver lobe at that juncture where the stomach meets and kind of becomes the small intestine duodenum. That area, pancreatic duct and bile duct, they meet. So there is a valve that's known as pylorus valve, and there is another valve located at the end of the small intestine known as ileocecal valve. So from valve of pylorus to the valve of ileocecal valve, the small intestine continues. About 20 feet approximately in length, duodenum, jejunum, and ileum is part of the small intestine. Mesentery is a visceral peritoneal structure that kind of holds the small intestine and the large intestine also to the wall of the abdominal cavity. It keeps them attached to the wall of the abdominal cavity, otherwise this will all come and kind of makes a lump together. The reason this structure is potent and the food can move through it because of the mesentery is attached to these small intestine and large intestine and holding it in place instead of like making it a big lump in the middle of the abdominal cavity. Mesentery also does a major transportation, nutrient transportation by mesenteric artery and vein. Mesenteric vein takes out all the nutrients from the small intestine and the large intestine, and then it directly supplies that nutrients into the liver for storage for future use. So mesentery has two functions: one to hold the small intestine, large intestine structure to the wall of the abdominal cavity, and also transfers the nutrients to store into the liver. We will find that when we're doing resection of small bowel or large intestine, surgeon has to go through this mesentery and resect the mesentery in order to get to the portion that needs to be resected using suture technique, ligation technique, or stapling technique. So mesentery needs to be divided in order to divide the small intestine or large intestine. So the whole section of small intestine further digests the food, absorbs all the nutrients, and allows the rest of the material of the food to move to the large intestine. And large intestine, as you know, starts at the ileocecal valve right here at this area where the ileum, the distal part of the small intestine meets or enters the large intestine's starting point, which is the cecum. And at the lower end of the cecum, there is a tail-like structure, which is known as appendix. This appendix stores a lot of E. coli bacteria. And that is why time to time appendix gets inflamed and appendicitis takes place, inflammation of appendix takes place and requires appendix to be removed. Cecum is the first section of the large intestine, and large intestine then moves upwards towards the liver, right liver bed. Underneath that right liver bed, we have a flexure called liver flexure, or liver has other name. Terminology wise, liver is known as hepatic. So hepatic flexure. That is where the colon from cecum goes upward. We call it, since it is going upward, ascending, so we call it ascending colon. Then it journeys parallel to the ground, or transverse journey. That is why we call transverse colon. And the end of the distal end of the transverse colon now reaches spleen area underneath the stomach. Spleen area, it goes downhill. So we call this bending of this transverse colon downhill. That area, we have another flexure we call splenic flexure. Splenic flexure, and all the way to the end of this colon, which is going downhill, we call it descending colon. Descending colon then turns and forms a S shape, and we call, because of this S shape, we call it sigmoid colon. Sigmoid colon's distal end becomes rectum. A rectum's distal end becomes anus, anal canal, and that is how we eliminate the extract of the food material. End of the digestion, all the water is absorbed here, and the stool is eliminated through the anus. About 5 feet in length. So how this ascending colon, transverse colon, descending colon stays like this? Because of mesentery that is attached here, and mesentery is holding the structure in this formation to the abdominal wall. To the back side of the abdominal wall, the mesentery is attached, and this is why this shape is intact. It is not like piling up into the center of the abdominal cavity. It stays as it is supposed to. So cecum to all the way up to the anal canal. That is the total journey of a large intestine. Now, anywhere, including the appendix, if we have any obstructions or inflammatory process, cancer, that area needs to be resected. In that case, we need to ligate the proximal and distal area of the inflammatory area, and then staple or suture, and continuity is maintained through anastomosis, putting together the rest of the colon. Sometime for cancer, patient is required to have total removal of this whole large intestine from cecum all the way up to the rectum. Then the ileum, where the food comes, has to go through the outside of the body with a bag. A bag is attached to the skin outside of the body, and that is where the ileum will be taken out through the skin incisions and attach it to the body bag, outside bag, which is known as ileostomy bag. So the whole large intestine will not be there. Instead, food will be, the elimination process will be involved with that ileostomy bag. Ostomy means opening. So ileum is open outside of the body cavity to eliminate the stool. Sometimes we don't remove total colon. We remove up to the rectum, and then we can make anastomosis of the ileum, this part, to the end of this rectum area. If the pathology, if the disease condition allows us to do that, then we will have an end-to-end anastomosis of ileum to the rest of the colon structure. Sometimes we resect lower part of the colon, then upper part of the colon has to be mobilized and attached to the remaining part of the colon. So there are many types of resections and reattachment process becomes part of this large intestine surgery. Colon is identifiable by this structure, white band that sets the colon as a different structure than small intestine. This white band sits in the middle of the colon. It's called tinea coli. This tinea coli allows us to distinguish colon from the small intestine. Otherwise, sometimes small intestine becomes larger in diameter, and the colon and small intestine cannot be differentiated. Inside of the colon, we have hastrae. It is a fold-like structure like this area, wave-like structure, sac-like, mini sac-like structure, kind of goes wavy all over the colon. These are called hastrae. Individual, this rounded bag-like structure is called hastrae. Appendix has fatty structure around it, and those fatty structure around the appendix called mesoappendix sometimes. We will show you mesoappendix when we are going to discuss the removal of the appendix. So this whole large intestine mostly absorbs water and does the end of the digestion process. So diagnostic procedures, we have seen in the previous chapter that we do upper GI tract scoping using scopes to see, visualize esophagus. A gastroscope are used to visualize the inner mucosal lining of the esophagus. So we call it esophagoscopy. Same gastroscope, when we advance it into the stomach and visualize the interior wall of the stomach, we call it gastroscopy. When we advance the scope further down and look at the duodenum, we call it duodenoscopy. So in total, we call it upper GIS or upper gastrointestinal series. Sometimes we need a substance called barium sulfate, and we have the patient takes this barium sulfate, ingest this barium sulfate, and they go through diagnostic CT scan. This allows this whole structure, upper GI structure, to scan through computerized tomography. For cancer detection, this is a very good study, CT scans of upper gastrointestinal series. Lower GI tract would be when we do colon scope, sigmoidoscope, proctoscope, anoscope. This is what we have seen in the previous chapter in detail. Here is another look to remind the flexible scope that is inserted to the esophagus, and the tip of the lens and the fiber optic light cable. Now, visualizing the inner lining or the pathology of the stomach. That's basically gastroscope. Colonoscope, on the other hand, the scope is inserted, flexible scope is inserted through the anal canal to the rectum, into the colon, all the way up. It can go to the cecum part and visualizes the interior part of the colon. That is colonoscopy. When we do these scope, which is going through the natural orifice, this procedure is not stereo anymore. Right here, it is going through another natural orifice, anus. This procedure is not stereo. It's clean, but not stereo. The reason is natural orifice has microbial organism, natural or residential flora. Those microbes are contaminating this process. So that is why we call it, this is a non-stereo but clean procedure. Anytime we are examining through natural orifice, the process is non-stereo. This would be a good place to stop and take a break. We will continue in about 10 minutes, all right? Okay, folks, you can take 10 minutes break.